in addition to, if you don't mind, in addition to, just this morning, we completed our own training manual, which is modeled off your channel partner. So somewhere during this, I may add some things. We've expanded that section, or we've added to, or whatever, so everybody stays on the same page. Is that okay?
Okay. Yeah, sure. So if you want, I can go through this, and then we can, I guess, combine, or if you have any questions or want to cover anything that you guys have, however you want to do it is completely fine with me.
Okay, good. Excellent. Thank you.
Okay, you're welcome. So I'm just going to start at the beginning of this, you guys, and I will tell you, like I mentioned, I will stop kind of here and there just to kind of get a pulse and make sure that we're all understanding, and then just answer any questions after the specific tabs that we go through.
Okay.
Okay. So this first portion that we're going to go through here, we threw in a table of contents, and this one we've been in the process of updating. So I'll make sure that you have this DR after the call here. Can everybody see the screen, or is everybody on the internet, or are you guys using phones?
I'm using this internet, so I see it.
Perfect. Okay, that's what I wanted to hear. So we're going to cover this. I will send this out to you, DR, afterwards, so you can disperse as need be, okay?
Okay, thank you.
You are welcome. All right, so this first portion, excuse me, guys. First portion here is going to be just a mock sales script that we have come up with as a team to really help you guys in the field. Mainly it's for terminology use, to make sure that we're all using the proper terminology. This is opera specific, okay, so just keep that in mind when you're reading through it. It's going to be related to opera, not target, okay. What are the, I guess, you know, I'm not really familiar with you guys, DR, as much as some of the other ones, because I have a couple different accounts, but as far as, you know, you guys, are y'all really focusing on opera? Is that going to be your main focus?
Well, that's a good segue. Let me just kind of enlighten you. The name of the company is Medical Research Associates. Our objective is to have representatives all over the country. They'll be reporting to us here in Las Vegas as a primary office. Our Vice President of Business Development is Mark Sanders. He's headquartered in New York. We have on the line today two people. Roger, what's your town? I forgot. What town are you in? He just muted himself. Anyway, and Shane's in Las Vegas here with me.
Oh, I'm sorry. Roger's in the Vancouver, Washington area.
Oh, that's right, Vancouver, Washington area. And we have other people around the country that are coming on. They're in various stages of getting signed up. The fact that they're here today in this training means that they've already signed non-disclosures. They've already signed the agreement with us. They've already been provided some materials. So they're up to speed with us. But our objective is to sell both the opera, the treat, and the geez, that's brilliant, DR. Target. Thank you very much. You know, you have to forgive me. I am 69 years old, so I am subject to senior moments. Not often.
That is okay. I'm subject to blonde moments, so don't even worry. It's totally okay. All right. So that's good to know. Good background. I appreciate you sharing that. So we'll jump right in. This is, like I was mentioning, opera specific. So just, you know, keep that in mind when you're kind of reading through here. I won't make us role play right now. I'll leave that up to you guys to do, since you guys are already kind of familiar with, you know, opera itself. But the main things I want to point out from this are just the terminology, making sure that we're following that, because we want to make sure that whatever we have going on in the field, we're within compliance, okay?
Okay.
All right. So these first probably 10 slides or so are going to be mainly for you guys out in the field when selling. Okay, so they're going to help, you know, with terminology. As you can see, you have the sales script in here. And then I also threw this in here. So this gives you guys kind of an overview of the tier levels when presenting to investigators. Okay, so are you guys familiar with these tier levels? Yes.
Yes.
Perfect. All right. So you guys came into this with some knowledge, which is very helpful. So you're familiar with the tier levels, and you do see the 10 to 20, and then the 21 to 35, 36 to 55, 56 to 75, 76 to 100. Now, does anybody know what it takes to actually get qualified to be paid from these tiers?
Yes. They have to be
What is that?
completed and submitted surveys.
Okay, yes. So they would have to be fully completed, meaning that the baselines would have to have HIPAAs and informed consents, and then they do have to be submitted within a certain time frame. Absolutely. But before we can actually get an investigator to qualify for these payments, they have to have 10 covered participants. Okay? So when our implementation team goes out and implements a clinic, they ask for a list of patients that are coming in that day in order to help reach those first initial 10 covered. Okay, so before we're going to pay out any of these tiers, they would need to have, like I mentioned, the 10 covered patients. Mm-hmm. The easiest way to get those 10 covered patients are going to be having a large number of patients lined up for the implementation. Okay, any questions over that?
No.
Perfect. Were we aware of the 10 covered patients initially?
Yes, we are.
Perfect. I just wanted to make sure, because sometimes, you know, the 10 covered patients is kind of, you know, forgotten because we want to jump right into these tiers. So just make sure that the investigators are fully aware that your first 10 patients have to, you have to have your first 10 patients covered, and then they qualify for these tiers.
Well, I think the other important point to make, Jordan, is that we want to get as many qualified as we can. So rather than just looking for 10 people that might qualify, we should be looking for the maximum number that might qualify within an individual practice. Once we define them in terms of protocol, then we start breaking it down relative to insurance and then see who would qualify, and then break it down from there and start getting these people enrolled before we just say, well, you have to have 10. You know, it should be a process.
Absolutely.
Like a funnel. If you imagine it like a funnel, that's what you're going to do. Start with all the patients at the top of the funnel that are doing pain right now, that are in pain for one reason or another, after surgery, long-term chronic pain, whatever it is, and then start necking that funnel down based on the other criteria within the protocol.
Yep, absolutely. And we're going to come to another forum right now that is going to be of assistance to you guys when you're looking at those things. So when you're looking at a clinic and bringing on a clinic, there's a couple things that you want to take into account. As you were mentioning just a second ago, the number of patients that we see, which percentage of those patients are suffering from pain, scar, or allergies, and then what percentage of those patients have federal funded insurance. Okay? So those questions are very important when thinking about a clinic and their success. Okay, so this form that you see right here is called our practice analysis survey. This form has to be turned.
One of the things we're not doing is watching the questions over here. Mark had a question, and he said, "What's been their experience in helping the doctor get to that first 10? Is that complicated?
Absolutely.
Well, what's that experience been like, company-wide?"
Yep. Sure, absolutely. So we, our implementation team, in order for them to actually go out to a clinic and implement, they require a certain number of confirmed appointments. Okay. So what we've seen in the past for clinics that haven't been successful is if they only have, you know, a few to, let's say, 10 patients lined up while they're there, chances are the implementation isn't going to be as handy, if you will, and as informative to the clinic because they're not going to see that volume of patients while they're there. Not only that, but when you look at the percentages of covered versus non, typically it's about 30 to 35%, right? So when you're looking at that 30%, that means if they have 10 patients that come in, only 3 of those patients would possibly be qualified and covered. So the higher amount, the better. And our implementation team actually does a call with a new clinic before they actually head out for implementation to verify that they do have patients that are going to be coming in for the study specifically, and then making sure that they're really setting them up for success as far as the training goes. the more patients that are there, they're actually going to be the ones that are running the study and showing the investigators team how it should look.
Now, when that RCC goes out there, not only are they going to be
Absolutely. So they will be training the investigators while they're there. So they require a certain amount of time from the investigator in order for them to head out. And they also spend, you know, time with, say that the investigator has like a practice manager or a research care coordinator on site that's going to kind of be helping run the study. Then absolutely, they're going to spend time with them while they're there. And it's typically about a 3-day to 5-day span. Now, obviously, we know that they're extremely busy, so we don't take up the whole staff, but whoever's going to be involved in the study or be responsible for training everybody else, those are the people that we would want to spend time with. And then, of course, the investigator for at least 60 consecutive minutes. So they do train them on site, right in the groove of things when they're getting to know patients and things like that, and they actually show you exactly how they would do it. Okay, and then not only that, but before the implementation, so similar call to the call where they, you know, verify that the investigator's office has patients lined up, they also do a quick training over web too, before they even head out, so that when they get there, everybody's on the same page and they can just do examples. Does that make sense?
Yeah, it does, and it would behoove us then to ensure we don't waste your time or the RCC trainer's time, is that we should have, guys, at least 3 physicians ready to go in any market. 3 physicians. So if you've got, just going back to Las Vegas, Shane, if you've got 3 physicians that want to participate in this program, and we've already gone through their patients with them to identify those at the top of the funnel that might qualify, if we can get, say, 30 or so or more that might hit the top of the funnel, we can be sure that when the RCC gets here and we start bringing these patients in, we're going to have at least 10 to qualify. And so we don't waste the physician's time, we don't waste Clarity's money, or we don't waste your time or ours. So I think that's the approach that we need to take.
Yeah. That's a great point, And then I also want to point out too, like you were saying, you know, having 3 investigators in every market at all times. That's a fantastic point because, you know, as the implementation team travels around, you know, if they know that you're going to have 3 investigators within the market that are ready to go, they can jump around and do implementations, you know, 2 days here, 3 days here, whatever is needed. So in order for you guys to bring on investigators and do that quickly, we'll definitely work with you if you have investigators that are, you know, multiple investigators within one area. We would be happy to do, you know, back-to-back implementations to get you guys up to speed very quickly.
Excellent.
Okay.
Mark, did she answer?
All right.
Mark, did she answer your question? Yes, no, maybe. Type it in.
And DR, if you'll do me a favor, because I'm able to see the questions right here, but in order for me to share my screen, I can't really click off very easily. So if you'll do me a favor, feel free to relay any questions to me. Just stop me if questions pop up. I would really appreciate that if you can do that for me.
Absolutely, not a problem.
Thank you. Thank you. All right, guys. So like I was saying, this practice analysis survey here is a form that must come back with all of the investigators' agreements and paperwork. However, I stuck it in this front part because I think it's very important to know kind of what questions we're looking at and what questions we need to be asking before we even decide, is this clinic worth our time? Okay?
All right.
All right. I also stuck in here our lead generation order form. So we do have a program here at corporate where we actually generate leads, and we can offer them to you. They're about $150 a lead, but they do all of the vetting for you. They set everything up and all that good stuff. So there's little work on your part that is required except for showing up and continuing the relationship. Now, some groups use these from the get-go. Some people have a little bit of a network that they want to go through first, and then they look at these. However you want to do it, but this is definitely available to you at any time. just make sure that we are, fully understanding which geographical regions, and if there's places you want to stay away from, put that on here as well, okay? In order for this to be in effect for you guys, you would just fill everything out, sign and date at the bottom, and there is an email address right here that you would send that to, okay? And then we also included the phone number of Trip Affleck, who is in charge of the lead generation program, so you can see his phone number right here, okay? Any questions over this?
No.
Perfect. All right, you guys, so let's jump right into the studies really quick. We are going to start with the OPERA study. So what I've included in this portion here is just some helpful tools and information that just kind of give you an overview of the studies themselves. So feel free to stop me at any time if there's any questions you need answered. Okay? So this first one, like I mentioned, it's going to be a quick reference guide for the OPERA study. It's just a great overview when the investigator, is wanting to just, hear a little bit more, but they may not have the time. This is going to touch on all the main points. So in here, the things that I like to point out to you guys are OPERA is a study for participants that are between the ages of 18 and 64 and a half. Now, I say 64 and a half because we want legitimate data, okay? So if a participant comes in and they are 64 and a half, we still have about 6 months to collect their data. So we get a survey each month with the OPERA study. Okay, so keep that in mind when you're discussing with investigators, is that we really want to make sure that the participants that we have in here are between the ages of 18 and 64 and a half. If they are outside of those age ranges, they are not qualified. They are not a qualified participant. Okay? Yeah. Now, a couple forms that have to be submitted with a baseline survey. So when I say a baseline survey, I'm always going to be talking about a survey 1. So the very first survey that a patient would take. Okay. Now, not only do we have to receive the baseline survey completely filled out with nothing missing, but we also have to have an informed consent and a HIPAA form as well, signed and filled out properly by the patient. Okay. Any questions over the things that they would need to have in order for it to be qualified?
Okay, I have a clarification.
Sure.
Essentially, when we train the investigator, part of that training is for him to determine who goes into the top of that funnel, since we're using that analogy. Once he's determined that, I'm sorry?
Uh-huh.
Once
keep going.
Once he's determined that, then it's going to be up to staff and ultimately the RCC to make sure that everybody gets enrolled and so on and so forth. When in part of that enrollment is doing that baseline survey, does that have to be done by the physician or the investigator, or can that also be done by the physician's intake person who presumably would go through the training with the physician at the time they're there?
Absolutely. Great question. So yes, it can be done by anybody in the practice that is helping run the study. Now, keep in mind the prescription side, of course, would have to be done by the physician,
right,
or an additional prescriber. So I always say, it's great. The best way to do it, I feel, is to have the investigator involved on the start, so the initial baseline. But by all means, the PA or the clinic manager or whoever it may be can be the one that's actually going over all the documentation. Absolutely.
Okay, good. Thank you.
Okay, you're welcome. I also want to point out here that we do not work with any federally funded participants. So Medicaid, Medicare, TRICARE. So that's definitely something on that practice analysis survey to make sure that that's a question that we're asking the investigator. What percentage of your patients that you see are coming from federally funded insurance? Okay.
Okay.
In order for a participant to be qualified and continue out the study after the initial baseline, they would have to be covered by their insurance. Okay. In the event they are not covered, They do have the option to purchase the medications at the cash price. However, if their insurance is not covering it, they would not be able to participate in the study itself. Any questions over that?
You're going to show us you're going to show us form consent and HIPAA forms, right?
You know, I honestly don't know that we have those forms in here or not. I can send them to you. However, I do not believe that we have them in this channel partner training documents right now.
All right, if you'd mark that as a takeaway to send us those 2 forms, that would be awesome.
I have a question.
Definitely, I am going to make a note of that.
Go ahead, Mark.
Okay, well, while she's noting, my question on the, I call it like the insurance triage. That's a real murky area today because of a whole lot of changes going on. I'm aware of the fact that we have an alternative formulary in the event that the first formulary is not covered. I know also that that takes time, and somebody specifically in the office has to do that sorting through. Up to this point, who has that generally been, and what's been the process, and what guidance do you provide to that person to make this adjudication easier, or is the adjudication done on the pharmacy side, and then feedback goes back to the provider to say this person does or doesn't qualify?
Absolutely, great question. So we do not, you know, by any means say, you know, you only should be, you know, bringing in these types of patients. Absolutely not. We do on the pharmacy side send what we call a disqualification letter if the patient is not covered. Okay, so we send that to the provider, and then the patient themselves is actually getting a phone call letting them know that unfortunately at this time your insurance isn't covering it. We have these options for you. So we give them the option to do the cash price, and then also give them the option to receive a sample. Okay. So that way we still can offer them something. So as far as the sample goes, if they try the sample and they want the cash price item, then by all means they have every right to order that, and we'll ship it right out.
Sure.
But as far as following up with the investigator and letting them know about which ones are covered and which ones aren't, absolutely. That is sent directly to the investigator's office.
So it makes sense, and again, if you have this information, great. If you don't, that's fine, I understand. Do you have anything looking over the last, because this is the reason I ask this, because this is a very dynamic situation. It changes from month to month as various PBMs approve and disapprove various medications and bases. Do you have any general kind of average positive adjudication rate, like 40% of them, or 50%, 60%?
Yeah, sure. I would say about 30%.
So then the
30
doctor,
to 40%.
right? So the doctor really needs to load the number of study candidates by that kind of an excess. So if he's looking to have 50 approved, he really needs to, you know, put 100 people into the study.
Absolutely.
Okay, I thought that was an important point.
Yep, no, absolutely. And that's why, you know, we were saying earlier about when our implementation team goes out, the more patients that you have, so if you have 50 patients, the more likely you are to get your, you know, 15 covered patients, which would qualify you for those tier payments. So that's why we really push at implementations to have as many patients lined up as possible, because we want to set the investigator up from the beginning, right? So great question. I appreciate you asking it. Does that help answer it?
Yeah, it does, because I'm aware of the realities in that part of the business today, that what used to be a slam dunk is a bit more pushing the rock up the mountain as far as getting people qualified. Now, I understand, and I'm just trying to make it easier for the prescriber's office, the PAs, etc. They don't have to do that triage. They will become aware of it, that, you know, it's a 30 to 40% adjudication rate. But I think that we've got to help them right up front in the first initial contacts to say that, you know, based on insurance coverage today, we're looking at X% probably getting covered here, so we'll need to look at an overage of enrollment to get there.
Yep, absolutely. Absolutely.
Also, Jordan, what do we have an idea, rough, and I mean really rough, of what a cash price might be for the pain medication?
Yeah, so I actually do have that. I have a sheet that I can send you guys, so I'll put that on my list to send you as well.
Okay, great. Thank you. Thank you.
You're welcome. And depending on size, I think the most expensive bottle is $100, and I want to say like $25 or so. And then it kind of, depending on obviously size, it goes down from there. So I will definitely send you that, but it's not above $150. Okay?
That's great. Super. All right.
Okay. Perfect.
Moving on.
I will get that out to you guys as well. Perfect. So another few points I want to touch on, this quick reference guide for Opera, is the length that we ask for is a 6-month study. However, you can go up to 18 months. So keep that in mind too. We do ask for the data to be legitimate and enough for us to use 6 months worth of. But you can go up to 18. And then I also want to point out as well, we are able to do these studies in 48 states. The 2 that we are not allowed to do these studies in as of this moment are New York and California. Okay.
Now, let me ask you a question, Jordan, on what you just said. If I understood you correctly, you said that we can do studies for 6 months. So I'm Dr. Rawson, and I've got these patients. And I know that for 6 months, I can follow the participants that we've selected that have qualified. But if I go to the 7th, 8th, and subsequent months, am I also counting them in the number of surveys that I'm putting out each month? In other words, am I compensated?
Yes,
all right.
You are.
Translated,
absolutely.
That means you have a longer recurring revenue stream.
Absolutely. And one thing I want to make sure that everyone's aware of, and I'm sure that you guys are, it sounds like you guys have some experience with this, which is great. But I do want to point out too, obviously depending on times of the year, we do see somebody who originally had coverage possibly not have coverage after 4 months or 5 months. So keep that in mind too. What's really important, and DR, you'll probably be more in tune with Salesforce as far as the patients and who's covered and who's not and things like that, because you should have Salesforce access. Now, keep in mind that you, as a channel partner, will want to make sure that you're relaying information back to these investigators. And if the reps are going to be helping manage these accounts, that's fine too. But everything that goes on as far as status changes and things like that, all of that will be in Salesforce for you, DR, okay?
Okay, great. And also a lot of that information should be in Iris, right?
Yep, absolutely, 100%.
Now, guys, if you think of Iris, think of it like our version of the doctor's office electronic medical record, because within there is the fact that they've completed the various forms that we discussed earlier, the informed consent, HIPAA, and so forth, and also whether or not their insurance has been approved for the study. So all of that can be found in the Iris once that doctor's office has received their training and they've been uploaded to the system.
That's correct.
Okay.
All right, so I'm going to go ahead and skip over to this guy right here. I'm not sure if all of you have seen this or not, but this is something that we presented at the International Conference on Opioids at Harvard Medical School, Pain Week, and the American Academy of Pain Management. So I won't touch on every single detail within these. I will tell you, DR, I don't know if you've already done it, but we do send these out to reps and panel partners. So if you would like us to send a couple copies to each of you, we can definitely do that. But this is a great tool for you when meeting with an investigator for the first time, second or third, however many it takes, to kind of let them know, this is where we presented our interim results. This is the outcome of what we saw in the interim results. And this also gives an overview. Like if you look down here where it says purpose, it gives you kind of an overview of the study. It gives you the age criteria, what types of patients would benefit from this study, so chronic patients with chronic pain, I can never say this word, but we'll just stick with chronic pain and other types of pain. So make sure to read through here. Would everybody like me to send this out to them, or have you guys already received it?
If you would send them electronically to us, I think what I hear you saying is that if the potential investigator wants this kind of information, we're free to supply it as you've sent it. Is that correct?
That's right. That's correct, but I will also say that we can send you guys, as reps or channel partners, we can send you guys a couple of these each, just so that when you go to an appointment, you have like a nice, like kind of blown up poster-sized laminate copy as well. So is that something that you would want, or do you just want it electronically?
No, go ahead and send those to us. You have my address at 47 Myrtle Beach, right?
Yes.
Okay, just send them to that address. We'll get them to the reps.
And how many would you like?
I need 6 sets right now.
Perfect. So I'll include a couple other things that will be beneficial to you guys as well. Okay?
Excellent. Thank you.
You're welcome. So like I mentioned, we're going to kind of zoom through these. I know we only have about an hour left, so I want to make sure that we cover everything. And you guys will be getting a hard copy of these as well as an electronic copy. But what we have here along with the quick reference guide that we just went over is the poster that or the interim results that we presented at the International Pain Conference. So let's take a look at just a couple things here and make sure that we're all on the same page. So we have these different charts. We have them throughout the entire poster. There's about 4 more pages of these. But it's going to give the investigator and you guys a breakdown of our interim results and the results that we saw. Okay, so I like to go over this guy right here initially with everybody, just talking about side effects and rashes, things like that. The reason why is because this is my favorite part of what we do. We're trying to, increase the quality of life of our patients. So, making sure that we're offering, an alternative method to these highly addictive opioids is very important to me personally. So I like to point this out. Out of the 389 people that were a part of our interim results, only 98.2% said, or excuse me, 98.2% said they saw no side effects, and then only 0.8, which was 3 of those patients, saw any sort of rash or side effects. Okay. And then there's other charts on here as well that are going to be beneficial when going over with investigators. So make sure to take a quick look through here and familiarize yourself with that. Okay. I also like this one as well because it's very straightforward, to the point. But as far as convenience goes, so patient assessment of the compound itself, 88% said yes, it was convenient. Only 12% said no. Application, 95% said easy to apply. Only 5% said no. And I kind of like to touch on these two real quick. So the things that we hear back from patients regarding, the application and how convenient, the things that we hear aren't so much on the, impact that the applying has, but make a lot of them say that, oh, it's not so easy to apply because it's sticky, so like my hair gets sticky, gets stuck in it. So I like to point those things out. So as far as convenience goes and application, those are the things that we hear. So if an investigator were to ask you, well, what are the things that they're hearing that, would say that they're not convenient or not easy to apply? So just let them know the things that we hear for the most part are just going to be more the thickness or the stickiness. It is the cream, so obviously they're going to have that. So just kind of a quick overview of the things that we hear, okay? And then preferred over oral medication, 80% said yes, 20% said no. Overall satisfaction with topical, 57% said very, 38% saying somewhat, and then 5% saying not at all, okay? We also have our references page here. A lot of times we do like to see the references and where they're coming from, okay? Any questions over that?
That was excellently presented. Thank you.
Sure. So let's jump right into Target now. So we talked a little bit about Opera. We'll jump into Target. One thing I want to point out really quickly is that Target is no longer a standalone study. DR, has that been shared with you guys already?
It has not. Please tell us more.
Yes. Okay. So I apologize it hasn't been shared. It came out last week. But because of the current adjudication rate with Target, we are asking that it not be a standalone study. So when an investigator is signing up for OPERA, they could then sign up for Target. But unfortunately, at this time, they could not just sign up for Target by itself.
Okay.
Okay. OPERA, on the other hand, can be with Target or a standalone. Okay.
Okay.
The reason we're doing this is because, like I mentioned earlier, we want to make sure that we're setting our investigators up for success. And currently, with Target, the adjudication is only about 10%. So combine that with OPERA, it doesn't look so bad, right? But if they were just doing a Target study, we want to make sure that, you know, we're setting them up for success. And unfortunately, they would have to have several patients in order for them to be qualified at all. Okay?
Okay.
Perfect. So quick reference guide is very similar to the one that you've seen before, except the Target study has a few different little things about it. Okay. So the participant age requirement here is between the age of 6 and 64 and a half. Okay. So keep in mind that we have to have enough months, so enough data in order for it to be useful data. So that's why we say 64 and a half. So 6 to 64 and a half. They also have to have, along with their baseline survey completely filled out, they have to have their informed consent in HIPAA. So across the board, the survey process is exactly the same, and the requirements are the same as well. Okay?
Okay.
Now, this study is up to 9 months, but they do surveys every other month. Okay? So keep that in mind. Say that an investigator is enrolled in both OPERA and Target. They wouldn't be able to do a monthly survey with Target like they would OPERA. Okay, so they would have to alternate those. Okay, and the total number of surveys. Go ahead.
From an aggregation perspective, if you have a physician who's signing up, we'll just say that it's in tandem, you've got 10 patients that are all on OPERA, and just coincidentally, 10 of those patients are also burn or scar patients. That really counts as 20 patients then, doesn't it?
Absolutely.
Okay, just wanted to make that clear.
Yep. I know the term double dipping is you know, technically a negative term when used, but in my mind, this is double dipping in a positive way, right?
Right, absolutely.
Better for all, you know. But yes, absolutely. And so those tier levels that we went over real quick previously, those tier levels aren't study specific, okay? So they don't have to have a certain tier level for OPERA and a certain tier level for Target. It's not study specific. So they could have 20 patients in OPERA, survey submitted, and then, you know, 5 in Target, and that would get them to the second tier if they were all quality, had all forms, and all that good stuff. Okay?
Okay, good. Excellent.
All right, perfect. So same thing with this one. We can do the study in 48 states. The ones that are excluded are going to be New York and California. Okay. Any questions over the requirements as far as when submitting a patient or enrolling a patient and then becoming qualified, or the length of the study and number of surveys?
Anybody?
I have another question.
Okay, go ahead.
You have another?
Yes. Is there any thought in your mind that the states of California or New York will have any sort of change? I know this is a state level policy about these types of studies, but is there any rumblings that any of that might change, and what the criteria would be to make that change?
You know, that's a great question, and I wish I could answer it for you. I can look into it, but I have not heard of any changes because I have been doing this for about 6 months or so, and it's been the same ever since I've been here. So I can definitely follow up on that if you'd like, but unfortunately I can't answer that one.
That's fine. It's one of those could do, not must do. So if you get a chance, find out something interesting. If you don't waste your time. Okay.
Okay, I'll write it down just in case, and we'll see what the answer is. All right. So this next poster or journal, if you will, is for Target. So very similar layout to what we had before, but this was presented at the annual SCAR Club conference in France, and then also the European Tissue Repair Society. So I want to go through this quickly as well. It's got the same exact layout. So down here under Purpose and Method, it's going to give you, and also the introduction, it's going to give you a quick overview of the study itself. It gives you the age criteria right here, and also gives you kind of a overview of what the medication is made of. Okay, so I will also send you this guy along with the opera one as well. Okay, and I'll send that to UDR, those 6 copies. Okay.
Okay.
So these next few pages are going to be a part of this poster here. And when we send them out, they won't be all on one sheet. So it's going to be a large laminated sheet that you can take with you from place to place. Okay? And this gives the same exact information as far as the layout and what all it entails. It's just related to the SCAR study versus the pain study. Okay? Also has these handy-dandy charts and graphs for easy reads and easy to cover with the investigators. Okay? So we'll just read through a couple of them. These are questions that we've asked to the participants. So have you noticed a reduction in size of the scars since you started the medication? So out of 109 patients, 69% said yes, 31% saying no. Okay? And then this guy down here just goes over length of scar. So check that one out too. This is a really interesting one as well, and it gives you from survey 1 to survey 3. These are the results in size that we saw. Okay. Similar graphs here. Feel free to ask me questions. We're going to send those out to you guys, and I'm also going to send them electronically. So feel free to get back with me if you have any questions over anything.
Okay.
Okay. So again, just like the other one, you have the conclusion and the limitations down here. And then you also have a page of your references there. Okay? Any questions over that stuff?
That was really good. You know, previously we'd all looked at those numbers and go, oh, great, more Greek wording. So that was very helpful. Very, very helpful. Thank you.
You're so welcome. I'm glad. So we're going to go ahead and move into the investigator agreements. So we'll pop right into that. There's a few forms that are required along with the investigator agreement. Okay. The first one being the demographics form, which is this guy right here. DR, correct me if I'm wrong, but you guys haven't brought on an investigator quite yet. Is that right?
That is correct. We've spent the past 3 weeks building a foundation on this company that was never done originally. So that's what we're.
Well, great. That's
very
exciting.
We just literally started bringing people on last Friday. Roger, who's on, was actually our very first guy. Shane we just brought on yesterday. We've got some others that couldn't make this training that we brought on since Monday. So we're kind of excited. We're starting to get a lot of steam going here.
Well, great. That's very exciting. Please let us know what we can do to help you. Okay. So these forms that we're going to go over here, like I mentioned before, they are required with any new investigator agreement. So we have the demographics form. One thing I want to point out to you, DR, I'm not sure who will be responsible for signing all of these for you guys, but we do require that the name of a channel partner sign this portion here and also date.
Okay.
Okay, so keep that in mind. We do all of these electronically, so I'm not sure if you guys have had the experience of going through the training for that. It's kind of separate, but I believe you guys work with Taylor. Is that correct?
Yeah, Taylor and Amanda. Mm-hmm.
Okay, perfect, perfect. So I want to make sure that if you guys haven't had the electronic document sending back and forth, that's how we send agreements. So we'll need to make sure to get you guys set up with that, okay?
Okay.
All right, so the demographics form is the first form, and then we have, of course, the W-9, and then I don't know if it's in here or not. It's not, but the practice analysis survey that we went over at the beginning, I believe it was like the 3rd page, that is also required. Now those things are going to be sent directly to the investigator, so you guys won't have to worry about getting those back and forth and things like that. They're sent to their email electronically, they sign them. Any other approvals or anything that would need to be signed is sent to you, and then it's sent directly back to us all electronically, okay?
Okay.
All right, and then we're going to jump into the actual agreements themselves. So we have 2 different types of what we call a master agreement. So the first one we're going to cover is the supervising agreement. Now, the supervising agreement, are you guys familiar with the difference in the supervising and the individual?
No.
All right, this is going to be great learning then. So we have the supervising clinic master agreements. These are for, say that I'm a clinic owner, okay? I own a clinic that has 4 investigators within it.
Okay.
I, as the clinic owner, can sign a supervising clinic master agreement, meaning that all of the money from our production would come directly to the clinic owner, okay? From there, the clinic owner could pay however they see fit. So they could divide it evenly, they could pay one more than the other if they're the actual one that's participating. However they want to do it, the money would all go to that one clinic owner. Okay? So those tier levels, I'm going to give you guys an example really quick. So say that I'm the clinic owner and I have 4 investigators. Okay? And I'm going to have 2 of those investigators actually sign the study agreement. Okay, so 2 of my investigators sign the study agreement, and the other 2 are going to be additional prescribers for those 2 agreement holders. Okay. From there, say the first month or second, whichever month, the first investigator that actually holds an agreement hits the 3rd tier, which I believe is, I want to say 5,000, somewhere in there. Okay, the second agreement holder hits the $10,000 tier. That $15,000 would go directly to the supervising clinic owner.
Okay.
Any questions over that?
No.
Perfect. So on the actual study agreements, like I mentioned, each investigator will have to sign a study agreement. Okay. On that study agreement, it does not talk about the financial portions at all. So they do not have any idea of what the tier levels look like. Okay, and that's just with a supervising clinic.
Okay, so what we're talking about here, if I understand this correctly, if we're going to an individual investigator, Dr. Smith is an individual guy, he's one guy in a clinic or one guy in a practice, and he does it. He's going to be aware of Exhibit B, which is the compensation. However, if Dr. Smith is under the pain clinic and it's got Smith, Jones, and Smythe all under that clinic, then their agreement will not have an Exhibit B.
Correct.
Okay.
So that's right. So here's how it works, and I'm actually going to walk you guys through these forms real quick. Okay. So the one that we're looking at first is going to be the supervising clinic master agreement. Okay. So this is the agreement itself. As you can see, right here is where you would list they would list their cities. So Opera, Target. Okay. Then here we have the actual compensation. Okay. So this is going to be on the supervising master agreement. Okay. After this portion, those 2 investigators that I gave you the examples of would receive this agreement only. So the one that you can see here. So we have the study agreement specific for Opera and then specific for Target. So if it was a supervising clinic, the participating investigators would only see this agreement that I have up.
Okay, good.
And yes, to answer that question, Mark, we would initiate these agreements. So what would happen is, sure, what would happen is you guys would enter the lead into Salesforce. From there, you would convert the lead and it would ask you which agreements you want to send to the investigators. There's little buttons that you would select, and it would automatically spit them out from Clarity. From that point, once those went out, the investigator would sign them. The ones that came directly back to us, we would receive. The ones that require an approval from a channel partner would be directly sent to that channel partner once executed by the investigator. Once the approval has been received and signed off on by the channel partner and submitted, it would come directly to us.
Okay, now let me provide clarity for those people on the phone and those people who will be on this training in the future. What you've just said indicates that sometimes the channel partner, in this case Medical Research Associates, will require approval. That's because sometimes the physician will go direct to you. However, so that you guys never fear, once you have entered that clinic into the Salesforce database and show them as a prospect assigned to you, Roger, you, Shane, or Bill, or Bob, or whomever, it's hands off for everybody else. Clarity will not be going direct. No one else will be able to touch that prospective customer until a given period of time has elapsed where you've failed to convert them. Until that time, that's assigned to you, which means that once that agreement's done, it'll have to come back for either Mark or I to sign that document.
Absolutely.
Okay.
All right. So this one that we're looking at right now, this agreement, is the same thing that we just saw before, but it's target specific. So as you can see right here, relates to target. Okay. So I put both of these in here so that you guys could see the difference in the target study agreement and the opera study agreement. So they're essentially very, very similar, except obviously one is relating to the SCAR study and one is related to the pain study. Okay?
Okay.
All right. So any questions over the supervising clinic agreement?
I don't.
Perfect.
Yes.
Okay. Perfect. Okay. So we're going to jump into the individual study agreements. This one is a lot more simple because it's only going to one investigator. Okay. So say that I'm an investigator, I have a private practice, it's just going to be me and I'm going to be receiving all the funds for my time and for the data. Okay. This one does also require the study form, so we'll get there in just a second. But what I want to point out here is that the tier level, so whether they are a supervising clinic or an individual clinic, the tier levels are going to be exactly the same. Okay. Now, same thing from the supervising clinic. They're going to fill this out incomplete, and then we do also have to have a study agreement for that individual investigator as well. Okay, so these look very similar as well. One is for the supervising clinic and one is for the individual clinic agreements, but same thing. You have a study agreement for OPERA and a study agreement for Target. Any questions over that?
You failed to mention TREAT. Would you not also have a study agreement for TREAT?
I need to get with Adam. To my knowledge, TREAT is kind of been taken off the board for a little while. So I'm not sure. I don't know. Taylor should have mentioned that to you guys too. So I'll have to follow up on that.
Yeah, because
but I did not include TREAT in here.
We've not heard anything relative to that. We've been told as recently as 2 days ago that it was still all three. So if TREAT's been taken off, that's fine. We're gonna push whatever's gonna push, and OPERA obviously is the larger of the two opportunities, without question.
Okay.
So, go ahead.
Okay, perfect. Well, I'll get clarification on that for you. Like I said, I'm not real familiar with you know, some of these other accounts, but I just do the trainings, and then I have a couple other accounts myself. So I'll follow up on that for you as well. A little bit clarification on that. I know that we were looking at treats going out to allergists and ENTs only, and that was the primary reason behind that. So I'll follow up on that for you, okay?
Sure.
All right, so now we're just going to go over some general information and some questions that we oftentimes get either from the field or from investigators, just to kind of prepare you guys for some of the things you might get, okay? So when does a channel partner submit a supervising clinic master agreement? So we just covered this, so perfect timing. The clinic is being compensated. There are multiple investigators. Each investigator can have an alternate prescriber, and the compensation goes directly to the clinic or clinic owner.
And the multiple prescribers could be PAs under the MD, correct?
Yes, sir. As long as they can write a script, that would be just fine.
Yeah, well, in some states it varies, but here in Nevada, PAs can write a script the same as an MD. It's just that if you guys don't know, the MD, even if you have a really good PA, the MD is required by law to review the PA's work. So he has to go through the file and say, oh yeah, okay, they presented with this was the diagnosis, this is what they prescribed, and he has to sign off on it, on each and every file. So if the PA sees 20 patients that day, the MD has to sign off on all 20. So just a little side.
Perfect. So when does a channel partner submit an individual master study agreement? When there's only one investigator, they too can have multiple prescribers, and the compensation goes to the contracted investigator themselves. Okay. How long is an investigator's training? So when our implementation teams comes out to implement a clinic, they have what they call a checklist. Okay. The checklist is going to cover every single thing that they're going to be going over inside the clinic. So after they cover each portion, they're going to be checking them off the list. The last thing on the list is going to be receiving those 10 covered participants. Okay. Once those 10 covered participants are on the board, then that training checklist has been satisfied. Okay. Let's see, what counts as an investigator training payment? So I want to cover this in quite a bit of detail quickly. So we do require at least 60 minutes of the investigator's time while our implementation team is in the field. Okay. The minimum compensation that the investigator would receive for training is $200. The maximum is $1,000. So in order for the investigator to receive the $1,000 training payment, they would have to have the 10 covered participants within 10 days from the training start date. Okay, so another reason it's really important to make sure that the investigator's office itself is set up and has patients lined up. Because if they receive those 10 covered patients within 10 days, then they automatically receive the $1,000 training payment. Otherwise, if it's outside of those 10 days, so say on the 12th day they finally get their 10, they would only receive a $200 training payment.
So it's not based on an hourly rate, it's based on success. Because if you're telling me that the minimum rate is 200, we were led to believe it's 200 per hour. So if the doctor had to have, for whatever reason, I can't imagine, but 2 hours of training, that's $400 compensation the way we understood it. Now, if all 10 of those get signed up within that 10 days afterwards, instead of just getting 400, you would get the 1,000. But what I hear you saying is it's either 200 or 1,000, period. Is that correct?
Right, that is correct. So the minimum, so we do require 60 minutes of the investigator's time. So that's where that hour might, when I hear you say that, that's where that might come in. Okay. But the only time I ever see the training being paid is either 200 or 1,000.
All right, good to know.
Okay. And then I saw there was a question that came across that asked about number of patients to have lined up. Absolutely. So the more patients you have lined up, the more likely you are to get your 10 covered. So I wouldn't put a limit on it even to 25 or 30. I would say, you know, if that patient has a patient base, that over the 3 to 5 days that our implementation team is in the office, I would say have, you know, if they can do, you know, say that they're going to be there for 5 days, I would try to have 15 patients coming in every single day in order to reach those covered 10, because 10 is the minimum. But think about if they hit their 10 and they get into the tier payments, that's going to be, you know, the sky's the limit on income there, okay? So just make sure that, yes, we want to tell the investigator if you can have, you know, as many patients as possible, 30 to 50 patients come in over this day, this day, and this day, then you are going to be able to make money while we're here for the data that you're submitting. Okay?
Mark, the answer to your question is yes. So we recommend a 20 or 25 better way to go. In fact, if we're using a 1-to-3 ratio, then we need to have at least 30 in order to hopefully get 10. I think in all probability, you're going to probably have to have 35 in order to get 10, because there'll be some that might. Here's the other thing that we're not saying, is that if you've got, let's just say, a bevy of 100 patients, we're saying, and what Jordan's saying here is that only 30% of those typically qualify. But there's some other reasons why they don't qualify. The patient says, no, I don't want to participate. Then they don't qualify. Doesn't matter what their insurance is. They simply don't qualify because the doctor can't force them into this study. So that's the other piece of it that's totally unknown. So the doctor is going to present this, and he's taught how to present this, and that's what they're going to go with. But in the meantime, we have to look at it from the perspective of he has to have 10 as a minimum. We're trying to get him his $1,000, and at the same time, we're trying to ensure that he gets off to a good start, because every month the physician will continue to add new patients. If he adds 10, there may be only 1 or 2 that actually qualify for this. So he's only going up a couple at a time. If it's a really large practice, I was in one yesterday that had 4 clinics, 4 physicians. They're about ready to add the 5th. They have a huge population of patients. It's also because they do workers' compensation, so it can be misleading. But even the workers' compensation, if it's not an applicant procedure, if it's a defense procedure, that means the insurance company is paying for that medication. And they might likely qualify. We won't know until we actually get them signed up. So there's some things to be taken into consideration, but always remember that little thing that we talked about, the funnel in your head. Start with a big number, you'll come down to a small number. That's the way it works. Just as in selling this, you're not going to call on 3 physicians and then 3 physicians go, well, no. Why, that would be silly.
Right.
Why not call on 100 of them and then 10 physicians go, yeah, why wouldn't I do this? I don't know why you wouldn't do it, but yeah, okay, you're in. So here's this next steps, doctor, and those are some things that we'll discuss outside this meeting. But go ahead, Jordan, this is excellent training.
Good, I'm glad. Good to hear it. So, yes, everything you said, absolutely, though. I do think that we need to keep in mind also the age criteria, too. So if we're contacting some of these patients, some of them may fall out. Insurance, you know, is a factor, but there's also several other things. So great point there. So who is funding the research? Sponsoring pharmacies and other pharmacies contracted by Clarity to support the research. Okay. All right. What qualifications must be met to be considered a valid study participant? So we touched on this earlier, but we have the age criteria. Opera ages 18 to 64 and a half. Target ages 6 to 64 and a half. And I'm throwing that half in there because it's really important that we are able to have this data and it be quality data. If somebody were, you know, 64 and fixing to turn 65 in 2 months, we are most likely not even going to get the follow-up survey, right? So we would just have one, which, you know, obviously that's data that we can't use. Okay? All right, and then the insurance coverage. So we do not work with any federally or government-funded programs, like I mentioned earlier, including Medicare, Medicaid, and TRICARE. The medications must be covered by the patient's insurance. Okay.
Let let me address this just a little bit more, because I think that too often we're looking at this saying, well, if you cut out Medicare, Medicaid, and TRICARE, you're cutting out a big group. At any given time in any given practice, there's only a percentage of the patients that qualify for particular medications, period. It has nothing to do with Medicare, Medicaid, TRICARE. You could have United Health, you could have Blue Cross Blue Shield. Some of these do not cover certain types of medications. So within a given practice, a large volume of patients, and I've consulted to an orthopedic practice that had as active patients 5,000 at any given time. Only a percentage of those were actually covered by the regular insurance. The rest of them had to be covered by supplemental in order to get something that they could afford, or they had to pay cash or whatever. It's a constant issue. And so don't let it be something in your mind that you say, oh gosh, this is going to knock a lot of people out. Forget about that. This is just a qualifier. That's all it is. And this happens in healthcare all the time.
Yep. Great point. Thank you. And then also the signed required forms that we talked about. So any baseline survey that comes through would have to have a HIPAA and informed consent along with.
And it does have to have something else, and that's their medical ID card and their driver's license, a picture photo ID as well, right?
It does. However, we keep that completely separate because that's on the pharmacy side. So we don't, what we're training in here is going to be strictly clarity related. Now, they will have to have a pharmacy card, so their RX card, and then also their driver's license, so their ID. But that is not sent in with the survey information. That is sent completely separate, which is why I don't have it on here. But that's actually going to be sent to whatever pharmacy they're working with as an investigator. So we will assign them a pharmacy once we get them all signed up and we get their agreements back and all that good stuff. So when our implementation team goes out, they will make sure to show you, okay, this is where your survey documents go, and this is where your pharmacy documents would go.
Okay, great.
So IRIS handles all of the study and survey documents, so it's all electronic as well. So each investigator will get an iPad, or I say iPad, but because that's the most common one, but a tablet that they will actually enroll the patient with. So whether it's the investigator you get, or the research care coordinator, or PA, medical assistant, whatever it may be, they will be using this tablet that Clarity gives to them. So we'll ship it out along with our implementation team. They'll show up, have it for the first day of implementation. Now the pharmacy documents, those are faxed directly to the pharmacy. So you will not use IRIS for anything except for survey or study-related materials. Any questions over that?
No, that was pretty clear.
Perfect. Awesome. So when the survey submission closed for monthly investigators fee consideration, the survey submission stops on the last day of the month. They have up until midnight Central Standard Time. After that, we do not accept any surveys to be sent over. Okay. So in order for us to get everything entered in and pay them within a reasonable amount of time, we have to make sure that we're not going back and forth. So we've put a hard stop date till the end of the month, until midnight Central Standard Time.
Okay.
Now the next question says, go ahead.
Well, this raises a good question, though. Let's say that he's normally got 20 people involved, 20 participants, but on this particular month, only 15 actually managed to keep their appointment and come in. That means he's only going to get paid for the 15 that actually submitted a completed survey. But the next month, all 20 come in, which means the following month he's going to get paid for, rather than 15, he's going to get paid for 20. So they can miss a month with the survey, correct?
So they can miss a month, but here's the thing, is we're trying to collect this on a monthly basis. So absolutely, they can do that. However, I don't recommend it. What I recommend is them starting to call the patients, a couple weeks before their survey is actually due. Now the patient, this is really important to note, because we're using IRIS now, okay, and IRIS is electronic, they do not have to come in to take their follow-up survey. The patient can actually take their follow-up survey online through IRIS by themselves.
Can they call that into the doctor's office and have them answer the questions on the tablet they have and submit it?
Absolutely.
Really? Okay. That should make it easier. Yeah.
It absolutely should, and so that's what we're trying to make it as easy on the investigator and on the office team as possible. So 100% I would say yes, they can do it from calling in. A matter of fact, we do have a lot of people that do follow-up surveys via phone, and there's nothing wrong with that. Especially with IRIS now, if the patient doesn't have time to come in, by all means they could take it on the on their own time, or they could call the practice, or the practice could call them. I recommend the practice calling the patient and doing the the legwork for them to make it easier so that we can collect that data. But by all means, I would say yes.
Excellent.
I have a question. Try and make it quick here.
Sure.
Do we have, as a channel partner, and as let's call them the relationship managers, the people that actually go out and initiate the relationships with the practices and start the ball rolling, do we have any role in reminding the patients, or are the patients invisible to us because of HIPAA?
Great question, and yes, your very last answer there. So you as a sales rep out in the field, you do not have access to these patients. The only way that you guys would have access to these patients is if you signed, an agreement with the office. So I do have a couple groups that are structured a little bit differently, and how they do it is they are actually sales reps or channel partner, a part of the channel partner team. I wouldn't say a channel partner themselves, but we'll say sales reps. So these sales reps also serve as what we call RCCs.
Right.
So when selling the studies to an investigator, if you guys have enough people, and that's completely up to you, that you would actually place somebody in these offices, say 2 days a week, to help organize and send things in and things like that and run the study for them or assist them in running it, then that is one way that you could, of course, help with the patient load. But other than that, no, we have no contact with the patients whatsoever.
Thank you. Second question. Going back to what we talked about before, that this month the doctor only got 15 out of 20, next month he got all 20. Isn't it really based on the tier? So if the doctor had, let's say, 25 and he only got 15 or 18, he gets paid on the next lowest tier level, right? Because it's not a cost per survey, it's a cost based on a number within the tier. Is that correct?
Correct.
That's what I thought. Thank you.
Yep, so they could have anywhere from, I think it's 10 to 20, and that would give them the first tier. Mm-hmm.
One of the most important thing to note for our people on the call is that investigators do not get compensated per survey, period. That would be illegal, and we would fall completely out of compliance if we even intimated that. They're paid by tier based on the amount of work that's required to accomplish those surveys for the people we've contracted with. That's it.
Absolutely. Okay. Yep. All right. So let me see here. So when is investigator compensation issued? So investigator compensation is issued the following month, and we have up until the end of the month to send payments out. So, for example, right now we just got finished with February. So yesterday was the 1st. We have until the end of March to get these payments for February out. Okay. The reason that we say end of the month is because we do what we call a QC process. So we want to make sure that, we have everything entered in correctly. We really work diligently. Our QC team is awesome, and they, spend a lot of time making sure that everything we have in the system is everything that they received. Okay, so we give them a few days, so basically the first week of the month to get things situated. And then from there, our finance team pulls all the numbers, which takes a few days to pull everybody's. And then from there, we schedule what we call phone calls with like one main contact from the channel partner group to go over these investigator payments. Any questions over that?
Yes. So once the completeness of the surveys has been determined, you have till the end of the month. You finish on February 29th. You have till the end of March to make the payment to the investigators. When is the payment made to the channel partner, aka us, sent?
Sure. So you guys, there are certain things that are due at certain times. So I believe it's the 15th of the month that your fixed rates are due. So for example, when I say fixed rates, I'm talking about the marketing fee, which is, I believe, $1,000 a month. So the marketing fees, and then along with the management fees. I believe those are paid on the 15th of the month, regardless, because they're a standard, they're the same or they're on a cedared grid. Okay, so anything else, so as far as like what we call reimbursements for surveys and things of that sort, what you would do as a channel partner, and we would ask this for only to be submitted for one group. So for example, like all of you guys would not submit. Like if you're going to be the one doing a DR, then it would be just you to send it in to us, to our finance team. Okay. So what you would do is you would take your total number of surveys, and you would have to look at which ones were qualified and which ones were not. Okay. And then based on that number, from there you would submit your estimated number for finance to look at. And they would pay you according to, as close to that number as possible, according to what we have in the system. Now, from the day that you submit that, so say that you submit it on the 1st of every month, they have 15 days to get that paid to you.
Okay. I think that's enough said on this particular subject, but that correlates with what we already know. So I appreciate that. Thank you.
Sure. No problem. All right, so I threw this in here. So this is the guidelines for a patient to be re-enrolled. So say that they have been off the medication for 60 days. We are taking the surveys because we want to see the progress that is being reached because of the medication that they're on. So it's really important to know that each 60 days, or excuse me, they have to be on the medication for 30 days. So they should be getting a new script every 30 days. However, say that they are off the medication for 60 days, and we track this as well with the pharmacies. So if they're off the medication for 60 days, that patient would then have to be re-enrolled. So they would have to start all over with a baseline survey. Okay?
That's after
and
60
this is kind of a, go ahead.
That's after 60 days.
Correct.
Okay.
Now, I'm not going to cover this word for word because it's kind of a case-by-case scenario, but I wanted to put it in here for you guys just in case you got this question, which I don't think you will, but we do see it happen kind of, like I said, every now and then, case-by-case, okay? So it's here if you need it. All right. And this, again, just talks about the survey cutoff policy, so it's just talking about kind of what I laid out earlier as far as the QC process, and then when finance pulls all the numbers. But the main thing to remember here is that they have until the last day of the month, midnight Central Standard Time, to get their stuff in. Okay? Excellent. Perfect. So this brings us to some of the implementation FAQs. So this is geared towards our implementation team that we send out to actually get a clinic set up and implement it. Okay, I'm not going to go word for word through here because there's 2 full pages of it, but I definitely want to point out just a few things from each. Okay, so Clarity does have an implementation team in-house that we send out to implement each investigator. Okay. Each implementation specialist is qualified, trained, and for the most part, they've either been, they're a nurse's aide, a clinical medical assistant of some sort. So please know that we do several trainings, and we make sure that everybody's up to speed before we send them out. Okay. I also want to point out that our implementation specialists stay on site from 3 to about 5 days, depending on the size of the clinic and number of investigators. So say that we have like a supervising clinic that has 2 investigators under the same roof. We might stay for longer. It really just depends on the patient size. Okay. Another thing I want to point out is kind of the process that we go through to get clinics implemented. So what we do is from the time that we receive a contract back for an investigator, from that point, once we receive everything back, it goes through a due diligence phase, which takes about 48 hours. Okay, once we get the due diligence back and it's good to go, custom packs are created. So let me explain what a custom pack is. We have a study custom pack, and we have a pharmacy custom pack that is created by the pharmacy. Okay, so the custom packs are going to include the survey, also the forms and everything. What they're going to have for each investigator is they're going to have a specific investigator code at the top right of each form. Okay, so they're all going to be pre-filled out with the investigator's name and their code, so we know that those are specifically for this investigator. Okay, same thing with the pharmacy packs. They're going to prepare your the investigator's script pad. They're also going to make sure that the investigator's name and their code is on there as well. Okay, once those custom packs are made, they're sent over to our implementation team. Once our implementation team receives that, we have a lady by the name of Latoya West, who is responsible for contacting the investigator's office directly and setting up the implementation. I would say typically we do ask for about 2 weeks in advance to schedule an implementation. So from the time that the contracts are sent back, usually on average takes about 2 weeks for our team to actually get there. Okay, any questions over that process?
Yes, on the very first paragraph you indicate that they want to be reaching the 75 maximum participants. We're led to believe that 100 is the maximum.
It should be 100. Implementation actually provided us with this, so good call out. It should be 100.
All right, thank you.
And I will change that. You're welcome. Okay. A few things I want to point out on here that we did discuss earlier. So it's talking about here how many patients we do ask for to be available and have appointments for us when we come in. Now I mentioned earlier that we can't technically say minimum or maximum, but we do ask for at least 50 when we are setting up the implementation. Now we set the number 50 knowing that, you know, if we say 50, it's probably going to be 30. So we want to make sure, as we were talking about earlier, that in order to reach those 10 qualified covered participants, we want to have a large amount because we know some are going to fall out. So per the implementation team, we do ask for 50 participants to be scheduled, but I can tell you under no circumstances will we go out if it's any less than 10. Okay, any questions there?
No.
Perfect. All right, so we're going to jump into the software and applications portion really quick. How many of you guys are familiar with Salesforce? Has anybody used it in the past?
I have. I don't know.
Okay.
Has anyone else? Roger, Shane? I don't think Shane has. Roger, have you ever used Salesforce? Okay. And Mark, you've never used it before, have you?
I have some experience with it.
Yeah, okay. The two of us have experience with Salesforce.
Okay, perfect. So what I'm going to do is I'm going to kind of give you a quick overview of a couple things, and then I am here anytime to answer any questions. One thing that I will ask from you, DR, is that have you already gotten everybody set up in Salesforce as far as logins? Has Amanda helped you with that?
Curiously enough, just yesterday we received a form that allows us to sign people up for that process. Now, when we do, does it go to you, or does it go to Taylor or Amanda, or who does it go to?
Who sent it out to you?
You'll send it out to me?
No, I said who sent it out to you.
Oh, Amanda sent it to me yesterday.
Perfect. So Amanda will be the person you send it back to, and she'll be responsible for getting those in.
Excellent. Well, we've already adapted the form, and we've indicated our name on it and so on and so forth. So it'd be pretty clear it comes from us.
Perfect. That sounds good. We will get that taken care of for you then hopefully today or tomorrow. And then what will happen is once we get you guys all entered into the system, we will have to get IT to allow access to certain things. So what I'm going to do for right now is we're going to give you guys rep access, meaning that you'll be able to create leads and convert them. Okay? So we'll cover that really quickly. All right, so once you are given access, you will automatically get an email sent to you from Salesforce giving you a temporary password along with your username. Typically, your username is going to be the email that you provided on the sheet, okay? But you're just going to go to salesforce.com and hit sign in or log in, and you're going to enter your credentials here. Once you're in, this is what your screen is going to look like, okay? So what I like to make sure everyone's aware of is pay attention to these tabs up here, because this is where you're going to be doing pretty much anything that you need to do within Salesforce. The main one that you as a rep will use is going to be leads. Okay. So here you can see the tab at the top here. If you click on it and you're in that portion, it's going to automatically turn a reddish orange for you. From there, you're going to hit new lead right here, which is going to take you to this page here. Okay, so the lead drop-down box here is going to have a couple different options for you. Okay, and those options that are going to be allowed, I believe, are going to be supervising or individual. Okay, so depending on what which investigator you have, you know, one could want a supervising agreement, one could want an individual. That's where you'll put that. Okay, and then it'll take you to this portion right here. Anything in red is going to need to be filled out. Okay, so from the drop downs, like we're just using this one for example, where it says specialty. The specialties are going to be what type of doctor is it? Is it, you know, a dermatologist if it's a scar? Is it, you know, an ankle and foot doctor? It's going to ask you all of those things. So you're just going to choose the one that most appropriately fits.
Let me stop. Jordan, let me stop you for just a minute. We recently had compliance come back and say that a GP didn't qualify. However, we know for a fact that GPs are seeing pain patients all the time. Also scars, also allergies, a lot of different things. As insurance companies continue to push away from specialists and down to the GP, the question becomes, can a GP do pain studies? Can a GP do scar studies? Can a PG do allergy studies? Yes or no?
I would say compliance. I'm assuming when you say compliance, you mean Brian Mueller. Is that right?
Well, I don't know who it is in compliance. We don't have a in compliance.
Okay. Yeah, if our compliance department says no or not at this time, then I would have to go with them.
You get a
so we do have to take a.
Can you get a clarification on that? Because when we first began, going back a number of weeks ago, that was curiously omitted, and it seems to me that if GPs and insurance companies in general are pushing 2 GPs, why wouldn't a GP be able to do pain and or anything else? That's just the way it is. That's the way the world works.
Yeah.
The world worked 15 years ago, but today, that's the way the world works.
Sure. Yeah, I can definitely follow up with that. absolutely, and I'll get with Brian and see what he says on that, and we will get back to you. Okay?
Excellent. Thank you.
I personally haven't heard that they couldn't, but I don't know where that's coming from as far as on our end, so I'll definitely follow up on that. Okay?
Right. Thank you.
Sure, sure. So one thing I do want to point out really quick while we're on the screen, it is very important that we have an email address in here for your leads, okay? Because the email address is going to be required for every single investigator that we're submitting agreements for, okay?
Okay.
All right. So once you hit the save button, once you have everything in and you hit the save button, it's going to take you to this page here. And as you can see, congratulations, you have entered your first lead, okay? So we've put this tool in here for you guys so that you guys can have it with you whenever it's needed. But by all means, I would love to walk you through the first one, myself or Amanda or Taylor DR, so whoever your account manager is at that time, just feel free to reach out to them or one of us, and we could be, we could help you anytime you need it. Okay.
Excellent. Thank you.
You're welcome.
By the
Will
way,
you guys all be submitting your own leads, or will you, DR, be kind of handling the leads?
no, they're all pursuing their own leads based on either our direction or the data that they already have from clinics that they've already called on or individual practices they've called on. But one of the things I want to know here, guys, is that this looks a little confusing if you've never used Salesforce. It seems a little counterintuitive at times. It's really not. But here's the good news. Not only has Jordan and through Jordan, Taylor, and Amanda agreed to help you with the very first lead that you put in there, but good news, the training manual that we'll be sending out has this step-by-step as well. So you have lots of resources to help you through the process.
Perfect. Yep. And we actually have also the whole e-sign process. So the whole process that we use for sending out agreements, entering leads, converting them, all of that, it's really all one long step. Okay. So when you enter a lead, the main thing we want to do with that lead is get it converted, right? We want that lead to convert into an actual investigator. So from the lead process to the conversion process to the submitting of agreements, it's really all tied together, okay? The part that sometimes won't be tied is that some investigators will enter as leads and unfortunately they won't close, right? But I do have also a document that is specifically for e-sign and putting investigators through. So I'll make sure that you guys all have a copy of that, and if you have this already in your training document too, DR, that's even better.
Excellent. Thank you.
Sure. All right. So one function I like to point out, just like several other websites or data applications, it does have a search function. So at any time, say that you exit out and you're needing to find some leads, you can actually type in the name of the lead that you just put in, hit search, and it'll pull that up for you. Okay? Now this talks about the converting of the leads in Salesforce. We do encourage that you guys use this function. However, I will say, if this function is not used within Salesforce, it doesn't mean that you won't be able to convert. This is just for you guys' knowledge of knowing, like, okay, this is a new lead. We are working this lead. We finally contacted the lead. So this just kind of helps you guys keep track of what's going on. Okay?
This is, in effect, the sales cycle that you're looking at right here.
Right.
Okay.
Okay. So here we get to the convert portion. So after you've entered the lead, you're going to have this convert button here. So once you click the convert button, it's going to take you to this page here. It's going to ask you to put in an account name, which would be like the clinic name, whatever the investigator would like it under. So say that I have Clinic XYZ, and that's the name of my clinic. The account name would then be Clinic XYZ. Okay? excuse me, so make sure once again that all of these red portions here are filled out. And I will tell you there's certain things too, like it'll tell you if you haven't filled them out, obviously. So that's a help too. Anytime you get like an error message or something, it probably means that something that is red is not filled out. Okay. All right, so once you fill that out and hit submit, you've converted your first lead. All right, another function that we have within Salesforce is reporting. So I don't know as far as DR, you tell me, but the reporting is usually more of a channel partner helpful tool, or like if you guys had RCC that you were placing within a couple of the clinics yourself, it would be helpful to them. Investigators will not have access to this, however, they will have access to IRIS, so that is what they can use to look at the statuses whenever need be. But you guys as channel partners, DR, are you wanting reps to have reporting access? Do they need it? What are your thoughts there?
Well, the agreement says that they're supposed to have access for reporting purposes. From my perspective, I think it's from the Department of Redundancy Department. We have to report on that anyway as the full channel partner. The rep is not the channel partner. So we have to report on that. And it's something that we would review with the individual rep on a monthly basis, saying that you've entered 10 leads, we've looked at the status, what keeps you from getting it to the end, that kind of thing, so that we can help them, stay with them to ensure that the process completes.
Perfect. So we'll go ahead then and get you guys all set up. I have some reps who use the reporting, and that's why I kind of like to ask you. So some of our reps actually use the reporting, some of the channel partners do, and some people say, yeah, let's both have access, or some say, yeah, just have the channel partner. So that's why I like to ask. I personally think it's great if the reps are actually involved in looking at their reports and kind of their percentages and things like that, because it not only lets them know where they're at, but it also points out opportunities of growth. So I think it's great. We'll go ahead and find out.
Jordan, as long as the report that they're gathering can be locked into the information they put in and only the information they put in, we would have no objection. But we certainly don't want...
That's how it is.
Okay, that's fine. That's fine.
Perfect. All right, you guys, so I put this portion in here as well. So this is the IRIS user manual. Like I mentioned earlier, as a channel partner and the rep, you won't really be using IRIS. It's strictly for the investigators' offices and their RCCs. However, I wanted to put this in here for you to view at your own time. A lot of channel partners think that IRIS is a perk because we're actually providing the investigator with a tablet that we pay for from a corporate side. So it kind of is a cool little something when you come in and you provide them with a tablet. So I wanted you guys to be able to kind of go through here so that you can explain it to the investigators if need be, or if they have questions over it, you'll be able to answer those. It's not something that we typically cover in channel partner training. However, I wanted it to be included in here in the event that you guys needed it as a talking point with the investigator. Okay. One thing I will point out here is this is going to be what the main screen looks like. So this is the reporting function. The cool thing about IRIS is that before we had IRIS, investigators did not have access to Salesforce, so they couldn't actually keep a nice reported count of their patients and who was covered and who wasn't. So IRIS allows them the ability to look in there at any time to see who's covered, who's not covered, who needs a follow-up survey, and so on. So definitely use this as a perk if need be.
Do we have an image of the tablet that they're going to get?
I'm sorry, say that one more time.
Do we have an image of the tablet they're going to get?
I do not have an image. I could send that in an email with a couple of these other things if you guys would like. We use, I believe it's a Microsoft tablet.
Okay.
But I would be happy to take a picture of one and send it to you guys just so that you guys could kind of see what they look like.
Yeah, that'd be great.
Perfect, no problem. So guys, this kind of brings us to the end of our training here. Now, is there anything that possibly we went over that you would like me to go back over? Any questions that I can help answer at this time?
Yeah, I think we need to hear from each person. So, Shane, you've already got your mic on, so let's ask you first. Is there something that was covered here that you didn't quite understand or you want us to cover again?
No, everything's pretty clear so far.
Okay. And just as a general reminder, guys, you're going to get, we had just completed a manual based on what we had previously been sent, Jordan, so looking forward to this, and then we'll go back in and add our unique medical research associates data to it. But we really appreciate this. This has been literally the best training. So let me ask you, Roger, have you got everything, or is there a question that you have that wasn't answered? Something?
Just in the sales genie. That's pretty much it. That and what we are allowed to call on, because I just need to know, are we not calling dentists, or I'm not dentists, but chiropractors? We're not calling general practitioners. So I just need to know who we can call on so I can really hit this hard.
Okay, well let me reiterate that. First of all, it's not Sales Genie, it's Salesforce.
Or Salesforce, yeah.
And in the manual that we provide,
I like Sales Genie better though.
Yeah.
It's cool.
I have Sales Genie, yeah.
The manual that we provide will go through each of those steps. And
Okay.
the fact that Jordan and Amanda and Taylor have all indicated they'll help put that very first lead in, I think should be awesome. So if you get your familiarity from the book and then go through it live with them, that should really pretty much cement your training. Addressing the issue of the physicians, the thing that you're not aware of, Jordan, is that we have two halves of our company, and each of these people that we bring on have an opportunity to do two different things. Our primary focus is with Clarity and with the clinical studies that we're doing. Secondary focus is a company called Healthcare Financing. And healthcare financing can be healthcare financing for the expansion of a practice, to cover receivables, to cover anything, the death of a partner, whatever it is. Any of that could be a reason, and it does not have to be an MD. It can be a DC, DO, MD. It can be a psychologist. It could be anything in healthcare. And as some of you know, it could even be outside of healthcare, although we're not going to specifically go out there and make calls on those kinds of people. We established HC financing for the specific purpose of hitting healthcare providers. So I think that answers your question. Does it, Roger, or not?
No.
Okay, Mark, why didn't you answer the question? What did we miss?
He wants to know about chiropractors and GPs. So our chiropractors, now I can see that chiropractors are not, these chiropractors are not prescribers per se.
That's correct. That's what
I was going to say. Yeah,
Okay,
chiropractors can't prescribe. Now, if a chiropractor has, somebody within the office that can prescribe, then we can, look at that. But as a general rule, if they can't prescribe, they can't be an investigator.
Yeah, no, what my question was, can they have an RN come in, and if so, how often does the RN have to come in to make them qualified?
First of all, the RN can't prescribe. That's number one.
Oh, gotcha. Okay.
Two, there are some chiropractic, some practices out there that are looking at this idea of partnering with an MD, because the thing the chiropractor can't do, the MD can do, and they can share referrals and they can share physical therapy. There's a lot of different things they can do, and that's kind of a movement that's getting traction in some states, but not all.
Okay, awesome.
The truth is, from a marketing point of view, if we want to call it that, the realm of pain, we're talking about over 100 million people in this country who suffer from some kind of inhibiting pain, which is why they go to the doctors. Most of them are taking oral meds, that we've talked about, the analgesics and the opioids and NSAIDs, etc. That is really where the focus is, and that's a pretty specific set of doctors, whether it's neurologists or podiatrists, for example, is a big area. So we can talk about that specifically. But going back to GPs, again, GPs for pain issues tend to refer out, don't they, DR?
Most of the time, yeah. It depends. Some of the HMOs, in order to have a a specific referral out to an orthopedist, for example, or a podiatrist, man, you got to be real specific. Well, the metatarsal bone on his left, you know, that kind of specific. If it's just pain in the foot or the, you know, let's say the knee or something, typically the doctors, the GPs will treat it. But if they believe through the X-ray that they'll order or the MRI that they'll order that it's something out there outside their scope, they will refer it out in a heartbeat.
Okay, thanks.
You bet. All right. Well, Mark, do you have any other questions? You're kind of the last one. I have no questions. So, Mark, do you have any questions?
No, I'll just say quickly that how much I appreciate Jordan's efforts today. I thought it was an excellent presentation, and both for today and then for the posterity value that this has for anybody else in the days and weeks and months ahead that are listening. You know, it's a very straightforward process. It's kind of like, you know, mastering riding a bike. You know, you get going and you learn it, and there are training wheels here and so forth. There's plenty of help. And once you've done one or two of these, you become a past master, and everything else is fairly standardized because the whole process is very routinized, and it's just a matter of following the script. You know, so we have a wonderful resource to help a tremendous number of people in pain and practices that are in some level of pain as well, we could say. So that's all I have to say.
That's true.
Mark, I have a question for you. You said 100 million people are in pain. How many of the 100 million are chronic?
That's a very good question. Don't know that.
Okay. Well, still 100 million. And for those of you who may not understand, chronic means it's always been there. It's been there for 5 years, 10 years. I'm a former semi-pro football player, and I can tell you that from the time I was 25 until last October 1st, when I had back surgery, I was a chronic pain person, chronic back pain. And so some days I'd wake up and I couldn't even walk. Some days I'd walk in a lot of pain. Some days I didn't have any pain. But most of the days there was some level of pain. That's a chronic condition. Okay, Jordan, I echo Mark's sentiments exactly. I think you've done a phenomenal job. I think this package is a great package. I'm looking forward to receiving it, and we truly, truly appreciate your time.
No problem, guys. Thank y'all so much for taking the time to spend with me today. And if there's anything, you know, question-wise that, you know, pops up, you know, today or tomorrow or, you know, 2 weeks from now, just let me know. I'd be happy to answer any questions. DR, I know that you're working with Taylor, which is great. She's awesome. Just, you know, if you need anything from me, reach out. I have a couple things that I want to go over really fast that I make sure that I captured everything you guys are looking for from today on. So I know that I have to send you guys a copy of the HIPAA informed consent. You also want a cash price sheet, and then along with sending you guys 6 copies, so sending DR directly 6 copies of the marketing posters. We need to ask the question about treat. And then we also want to ask the question about the general practitioners, seeing, you know, what the compliance holdup there is and seeing what we get back from that. And then I'm also going to send you a copy of how to properly do e-sign. However, please make sure to use this as resources. If we can do the first one with you, we would love to. Anything that I missed?
No, I think that's good. But I think with the GPs, I think you need to add things like, well, specifically podiatrists and DOs.
Okay. I know DOs are a go. We do have DOs.
The DOs
and we do have podiatry as well.
Yeah. The DOs are very old. They were added in as an MD back some 10 years ago. But anyway. Okay, that's all.
Well, I will follow up on that question. Anything else before we hang up?
No, I think that's it. When can we expect to follow up with you? I mean, when can we expect the materials we discussed? As you get them? All in the next 10 minutes?
One more time, I'm sorry.
When can we expect the items that we've just discussed that are follow-up? Can we expect that in the next 10 days?
I would say by the end of the day. I can be pretty quick around here, so by the end of the day, I'll have that stuff to you.
Oh, that's awesome. That's great. That's awesome. All right. Thank you so much, Jordan. We appreciate it.
You're so welcome, guys. Have a great day. Thank you.
Thank you. Have a good day.
Bye-bye.
Bye-bye.